has arrived, and I know some of you have been patiently waiting for it. So how about taking 3 minutes, grab yourself some coffee, and then we'll begin. It's in the back room there. I'm so delighted that so many of you chose to be here this morning. I'd like to welcome you to the 21st Family Impact Seminar. We've been doing these seminars for state policymakers since year 2000, and this is a nice crowd, so thank you for coming. I'm a faculty member in the Department of Human Development and Family Studies. My name is Esther Onaga, and we believe in the department that families are a basic building block of society. Families are a cornerstone for raising productive workers in a sound economy and responsible citizens in a strong democracy. I had to put a plug in for our belief system. But even strong families struggle, and they are stressed by the inability to find a job, afford health insurance, secure quality childcare, and sending their children to good schools. The Family Impact Seminars are a series of presentations providing briefing reports, which are in your folders. And this information is delivered in a timely manner. Unlike many of the seminars, the advisory group picks the topic. I'm not an expert on healthcare, but we can scramble and find the best source of information and the speakers who can present it in an engaging fashion for you. We believe in the value of objective research and delivering the information to people who can really create policies that can make the lives of families better. Today we have seminars sponsored in 22 states, so Michigan is not the only state. All are university or extension-based. We have covered healthcare issues, economic development, juvenile and adult crime, childhood care and education, welfare reform, and family violence. This year, the Family Impact Seminars was recognized as a bright idea by the Harvard Innovations in Government program. These seminars are possible with the support of many people and organizations. We are fortunate to have the co-sponsorship from the House and Senate Health Policy Committees, and we have Representative Gail Haynes someplace. And Senator Marlowe would be joining us, and he chairs the Senate committee. We have had tremendous assistance from the Michigan Health Council to identify examples of the team care approach in Michigan. Drew and Don, people from the Healthcare Council, raise your hands. Okay, thank you very much. We also have received continuous support from the Michigan Department of Community Health. Melanie Brim helped us last seminar, and she's back again to help us. So I keep asking. We also had a very generous funder in the name of Kellogg Foundation, and we're grateful for that. In turn for the foundation's support, I will need to be accountable to them, and so we have green evaluation sheets. And I know that it's easy to ignore them, but they will help me write a good report to them. And so if you could help us in filling out the sheet, I really would appreciate that. And you'll get pie. That sounds Skinnerian, I know. Now I'd like to turn the floor over to Representative Haynes, who will introduce our speaker, Dr. Sevchuk.
Thank you very much, Esther. It is certainly delightful for me to be here with what I have come to feel is my MSU family. The Michigan Family Impact Seminars have always been very informational, and I really do appreciate MSU and all the work that they've done to provide these types of seminars for us. I would also like to take just a minute to introduce my vice chair in health policy, and that's Representative Mike Colton. I now would like to introduce our first speaker, Dr. Donald Sevchuk. Dr. Sevchuk is the Senior Associate Dean at Michigan State University's College of Osteopathic Medicine. His educational background includes Doctor of Osteopathic Medicine, MS in Pharmacology, and an MBA. Through his professional career, he has provided care to patients as a pharmacist, general practitioner, and emergency medicine physician, often in a team-based environment. As an educator and preceptor, he has trained medical students, physician's assistants, nurses, nurse practitioners, physical therapists, and pharmacists. And now today, he is here to educate us. So please join me in welcoming Dr. Donald Sevchuk.
Thanks, Drew, for fixing that. Well, good morning to everybody. I'll start with, I'm a huge introvert. So if I start talking really fast, you'll understand that I'm compensating for that need to pretend like I'm an extrovert for a few minutes. Mr. Paradise will attest to the fact that he just turned around and shook my hand and it's cold and clammy and sweaty. And my wife goes, I've been married 33 years, she goes, why do you do this if it makes you so nervous? And I do it because I enjoy it and I'm very passionate about certain things. One of them is this topic in professional education specifically. So I'd like to thank Drew and Donald and Craig and David and Ann and everybody else who put the slides together because they made my job real easy. And they said, you can talk about whatever you want. So because there was a recent program where there was a power outage, I brought a few notes that match my slides just in case the slides go down. But I'm hopeful that I don't have to use them. So let me begin with this. The Institute of Medicine published a report in 1972 that talked about building health teams. And it's taken us about 40 years, if you do the math, to really get to the point where that initiative has finally gained some traction. In the 1970s, I was in pharmacy school, and when that report first came out, I can't say that I read it, but there was a lot of discussion about the things that health teams could and should do to improve patient care, safety, outcomes, and a number of things. So I start with that because the good news was I looked in the evaluation forms, and you're not evaluating the speakers today because I would have been number 7 of 7. I know that. So it's good that I don't have to worry about that. But I looked at the things, that the before and after questions, and I'd like to believe that we will touch on all of them. In fact, I'm going to tee up a lot of that content and then get out of the way. So where are the students from Michigan State? Okay, so, I look, I make eye contact, and I want you to keep nodding like you're agreeing and I'm doing a good job just to help me out, okay? So, first and foremost, you take a look at that picture, and the title is Transformations in Healthcare, and what does that really mean? I mean, what is the message, and why did we start with this picture? Now, I'm a huge believer as an educator that if you walk out of any session, you've learned 5 things you'll remember for the rest of your life. It was a good day. And you have to stop and think about things. So to the students, I can stand up here till my time is up, and we're not going to go past the slide if we don't give you something. So what does that picture say to you? When was the picture taken, do you think?
How long do you think it was?
Somewhere around the turn of the century, around the 1900s. All right, if you take a look, what was the average life expectancy around the turn of the century?
45.
It was about 49 years old. That's exactly right. And what's the average life expectancy currently estimated to be about? At the time of birth, most people live to be about 78, 79. By 2050, what will the estimated life expectancy be? About 81. All right, so in the first half of the 1900s, we made tremendous advances with germ therapy, theory, a whole bunch of different sorts of things. We're not going to make big advances. So what's really happened is we've made tremendous strides which have really impacted how healthcare is delivered. Now, the interesting thing about this, and I wasn't there then, but in this era, in the 1900s, how many physicians were actually graduates of medical schools? 10%. 10% of practicing physicians around 1900 were actually graduates of medical schools, most of them trained in an apprentice model. There were pharmacists and there were nurses, but essentially there was nobody else. Okay, that's about where we stood at that point in time. So we fast forward, if I can find my little thing here and make it work, we fast forward to these new and evolving models of team-based care. So in '72, the Institute of Medicine I already mentioned came out and said there's some things we need to start to do. So back to my students, because I will continue to go to, because I'm not going to ask any questions of the state legislators or their aides, okay? But I totally have free reign with the students from Michigan State. What's different about this picture? It's recent. You take a look to your left, and we see some patients who are well past 65. We'd all agree to that, right? Then we kind of take a look in the middle of the picture, and we see a young lady with what we're assuming is her son. And we see somebody off to the right who is probably the father of the young lady who is the offspring of the folks to the left. We've got 4 generations of folks here. So one of the things that's become important to us as we deliver healthcare is we need to look at multiple generations of expectations, comorbidity. People past 65 on average, about 50% of them have at least 3 different chronic diseases. And that's changed the complexity of how we need to deliver care. Does that make sense to everybody? Okay, we got women's care, we got all these sorts of things, we got pediatric care, we got geriatrics care. Back in about 1930, there were 2 groups of physicians. There were general practitioners who were about 80% of everybody, and there were about 20% of the physicians who were specialists, and almost all of them were surgeons. Any idea how many specialties and subspecialties we currently have in medicine today? Over 140. 140, so we've really got to the point where we started to separate and segregate and compartmentalize a lot of things. Now, in 1965, the first nurse practitioners program opened at the University of Colorado. In 1967, the first physician assistant program opened at Duke with 3 students. Okay. Currently in the United States, it's estimated there's about 155,000 nurse practitioners, and there's about 93,000 physician assistants. In the state of Michigan, there are about 4,000 nurse practitioners, and there are about 3,100 physician assistants. So we start to look at this mix, this milieu, and it's clear that we have to practice in a team-based manner. So what does this mean for the state of Michigan, and how do we get there? I put this up as a transitional slide because I'll get to the demographics and a few things here in just a minute. And I'm always worried that I'll end a little bit early because as an ER doc, I like to get to the point. Melanie Brim told me she stands ready whenever I'm done to jump in, so we'll have a nice transition whenever that hits, all right? What does this slide say to you? Genetics, lifestyle, behavior, and the environment. Of all the diseases, of all the morbidity we currently experience, of all the things we treat as healthcare providers, what percentage of all of our maladies are caused by those 3 things? 90%. 20% are genetics, 50% are lifestyle and behavioral choices, and another 20% are the environment. So when we start to look at the places we live, and you walk into a store that provides services such as we see them, it's not unexpected that we are a bit challenged as a society by certain diseases like obesity, like diabetes, like heart disease. In the state of Michigan, 1 in 3 people who live in the state of Michigan fits the definition and characteristics of being obese. 1 in 10 patients in the state of Michigan has diabetes, and of the patients more than 65 years old, 1 in 5 have diabetes. Obesity, diabetes are huge risk factors for heart disease. So I won't even give you the numbers there. There's a lot of stuff in your briefing. I don't like to throw a lot of numbers at you, but I feel like as an educator, I got to give you a few. So there's a lot of moving parts here. West Michigan, when we get out of the way, will talk to you about their programs that have to do with obesity and the interprofessional initiatives on the west side of the state. FIS State has some programs where they're talking about diabetes and the examination that's required of diabetic patients to better help them understand the maladies that are there. And all of these things are happening as teams. So we're moving in that general direction. Now, what does it mean for the state of Michigan? Well, when we look at healthcare, it has an expense. It's complicated. There's a lot of things that go on, and we have a lot of things that we need to worry about. So, when we look at the state of Michigan and all of these things, I'm colorblind, so thanks guys for giving me this slide. So I'm going to go off of what you told me, okay? All of the little symbols represent different types of healthcare facilities. The purple areas are geographic distribution of health professional shortage areas, and the green areas are by population. They also define health professional shortage areas. The bottom line take-home message, and even for somebody like me who's colorblind, is I can see that we have a maldistribution of healthcare access throughout the entire state of Michigan. Okay, barring a few small geographic areas, this is widespread and involves the entire state. So what do we do about it? How can we get there? Team-based healthcare. So finally, I've set it up for you. This has been a 110-year journey. We've got there quickly. There's a lot of things happening. Some things are going to change. But with the complexity of where we are, it's clear that we need to have better outcomes coordinated through patient care. Of all the patient safety issues, of all the errors that happen, how many are dependent on communication that didn't happen between different healthcare providers? Any idea how many sentinel events are driven by a dropped communication issue? Between 70 and 80% of all healthcare safety issues are believed to be the sentinel event that involves some communication issue. Well, if we can get better about programming people and training them and getting them to think and be comfortable with one another as healthcare providers, communication should be less of an issue. I was at a hospital on the east side of the state, I won't mention the name of it, on Thursday last week. And there are some areas, and they're not just limited to geographic locations of the state, they're not limited to the Midwest, they're national issues where this is going to be a challenge for us. And I look forward to what's going to happen, and I'm just sad that my career probably won't last long enough to see how this ends. And I don't mean how it ends in the long term, I mean even in the shorter term, because it took us 40 years to get to the point where we're talking about it at the state capitol. I hope it doesn't take us 40 years to get to the point where we really understand this. Because as of 2008, the last time a big Cochrane review was done, you know how many randomized controlled studies that we're looking at interprofessional healthcare? 6. So we don't know a lot yet about the delivery side. We're working a lot on the educational side so that we can train the healthcare providers of tomorrow to be better positioned to understand what they can each deliver. So, when we look at the definition, I was told I have a wide group, so I'll start with the definition for those who aren't familiar with interprofessional education or healthcare. It is when two or more healthcare disciplines work together to learn from, learn about, and learn with each other about the delivery of healthcare, and that's World Health Organization 2011. When we look at competencies, there are 4 major defined competencies about what interprofessional education is. Number 1 is values. What are the values of a given discipline? I am not a big proponent, in fact you'll never hear me say except to say I don't like it. I don't like the term mid-level provider. I prefer non-physician clinician. I have for a long, long time. All right, so when we look at non-physician clinicians, regardless of whether they are pharmacists, dietitians, social workers, you run the list, they all have values within their profession. And those values define the roles and responsibilities of each of those professions. Those are the first 2 competencies. How do we value one another as healthcare providers? And what are the roles and responsibilities that are clearly defined for each of the healthcare professions as they exist? Then we get to interprofessional communication, which is the 3rd core competency. We need to be able to talk to each other. And what do you think the 4th core competency is after understanding each other's values, roles and responsibilities, communication? The 4th is teamwork. Teamwork is the development of the 4th competency. Now, flexibility, again, I don't have any idea what this is going to look like, but it's going to be interesting to try to help nudge it along as we all can, because we are one by groups. I've already mentioned West Michigan, I've mentioned FIS State. The University of Michigan is working on some dental programs with a lot of flexibility in the community to adapt to particular styles, which is key and demonstrates a part of this, so I encourage you to talk to them. And then we get down to the benefits. I mentioned earlier we don't have a lot of definitive data yet, but from the data we do have, it's clear that in geographic locations where interprofessionals work together, the number of emergency medicine visits goes down. The length of hospital stay goes down. The use of chronic medications for certain morbidities goes down. Patient satisfaction goes up. Total healthcare cost is estimated to go down by about 15%. Every way we slice and dice it, even though the data is limited, everything points to a positive outcome. And I think it's important that we start to embrace this, because I like to believe that Michigan is one of the leaders in this, because we got some really great people who are passionate about this, and you're going to get to meet a lot of them in just a minute. All right? So that's what this is all about. Now, Michigan's network of interprofessional initiatives. David, or Craig, because I forget you two guys are both, handsome young men and very hardworking. Which one of you runs the E2P initiative? David. Be sure you talk to David about the E2P initiative, because the Michigan Health Council is looking at ways to connect the training opportunities to make interprofessional training in our systems more effective, more efficient, more streamlined, more equitable, more defined, more a bunch of things. So 5 great programs, and I'd be remiss, and my colleagues from Michigan State would be unhappy with me if I didn't mention what's going on at Michigan State. At Michigan State, we just completed a 3-part series of longitudinal training of the faculty that work in the facilities where these interprofessional disciplines come together to practice, and the Michigan Health Council was gracious enough to offer a certificate. And we had a little over 100 people participate in that program. It started in February, just ended on September the 13th. First step we're taking towards starting to train the people on the other side that are actively practicing to be receptive of this, because it's a long training curve. So I will stop there. I told you I wouldn't be terribly long. I don't like to listen to myself talk. So I defined your professional education. I gave you the core competencies. I talked about the 5 groups of people that are working hard on some initiatives you'll have a chance to talk to. I did not mention the practitioner side of any of this. You'll notice I did that purposefully. I only talked about the educational side, and I told you that we're on a real learning curve here, and Michigan needs this. Michigan needs it for a number of reasons, especially when you look at how rurally based a lot of our folks are. With the Affordable Health Care Act, it's been estimated we're going to have 1.5 million more patients. How many physicians short are we going to be? How many nurses short are we going to be? And more importantly, how many of those healthcare professionals, the ones that I didn't mention as well, are we going to be short in these rural areas where it's harder to populate for particular reasons? So I hope I've given you some things to think about. I'll answer any questions if you have them. Sir?
If you look at the map of Michigan, we have a map also with our handout here. There are certain regions in this state that cannot sustain any traditional model of healthcare as we know it, due to demography, due to population density, due to economic considerations, and the whole population that you're dealing with. So the questions being asked of educational institutions, how do you fit into the safety net that's in your state, and how do you collaborate with other institutions in your state to address that safety net access question?
Great question, multiple layers. I'm not the smartest guy to answer it, but I'll give it my best shot, okay?
You got the mic, so you got it.
But if anybody else would like to answer it, I'll open the mic. I'm good to giving the mic up to people who want to discuss things. Technology, I think, is going to have to be one of our answers. Okay, we now are, not we because I don't do it, but we as a healthcare professional system do robotic surgery from remote sites. We do telemedicine. 80% of all diagnoses in healthcare are delivered through a history and talking to the patient. Only 10% of all diagnoses are dependent on the physical exam, and only 10% are dependent on all the labs and all the other things we do. And that's been replicated since 1970 repeatedly, because people wanted to believe the more MRIs we do and the more this and that we do, the better. It's not been validated with the studies. Talking to patients is critical to the delivery of health care, to their assessment, to their education, to their compliance or following instructions, et cetera, et cetera. So information technology is going to be one. Number 2, I'd like to believe, although I don't have data to support it, that the interprofessional educational models will allow people who know each other well to potentially populate some of these rural areas and collaborate together for cross-coverage, for consulting opportunities, for collaboration, because what's been expressed to me as a concern is I really don't have a particular problem. Now I'm quoting somebody else. I may not have a particular problem going to a rural area, but I feel like I can't get away for a vacation and enjoy myself because I'm deserting the community. So as we look at ways to do this, as we look at ways to do this, I think there's a lot of potential benefit through technology and collaborative models of the disciplines we're practicing and working together. Best answer I can give you today. Anything else? All right, well, I appreciate the opportunity. I've given you a few things to talk about. I will move on to let Melanie Brim be introduced, and I thank you for your time. I'll be around till 1 o'clock if anybody has a question.
The chair of the Senate Health Policy just arrived, taking notes there, and he will be introducing Melanie Brim. This is Senator Marlowe.
Good morning, everyone. Before I get into the introduction, I just want to point out that what you've been talking about, the topic here today and moving forward with healthcare, I've been working on some of these issues for 2.5 years. Next week seems to be our target that we will be coming out with these. I've been in discussion for over the 2.5 years with Chairwoman Gail Haynes, and I am meeting with Director Haveman and Melanie next week to go over this package of bills. And it's been sort of, you can have a child in 9 months, and we've been working on this for 2.5 years. It's very, very important. And Dennis is laughing over here, yes. But these are issues that are going to be of the utmost importance for the entire medical community in the state of Michigan. And now back to the topic at hand. Melanie Brim, I'd like to introduce. She currently serves as the Senior Deputy Director for the Public Health Administration for the Michigan Department of Community Health. Ms. Brim was appointed to this position in January of 2013. In this role, she is responsible to the Director for Management and the Director of Public Health Programs and Policies, Healthcare, Workforce, and Nursing Policies. Melanie also serves as Project Director for CMS State Innovations Model Planning Grant, and for the purposes in which to develop recommendations for new payment and service delivery systems. Melanie has held various other positions dealing with the licensing and regulation of Michigan health professions, served as the director of the Bureau of Health Professions from 2002 to 2011, served as a regional health administrator for the Michigan Department of Corrections, and director of clinics and therapists for the Grand Rapids Home for Veterans under the Department of Military and Veterans Affairs. Prior to her 19 years in service, Melanie worked in a variety of health care settings, including acute care, community-based health care, mental health, physician's practice management. Ms. Brim is a graduate of Indiana University, where she received both her BS in Medical Records Administration and a Master's in Health Administration. If we could give her a warm welcome here this morning. I have a wealth of knowledge that I enjoy having discussion with whenever I can. Well, thank you.
Thank you, Senator Marlowe. Good afternoon to everyone. I'm going to start by talking a little bit, giving some context to why interprofessional practice has been, about both interprofessional education and interprofessional practice have become important issues for the Department of Community Health. You know, as we have nearly 1 million people who are going to gain access to the healthcare system next year, either because they become eligible for purchasing coverage through the health insurance exchange, which goes into effect January 1, or because they will be eligible for the Healthy Michigan Plan, which goes into effect April 1, we obviously are increasingly concerned that there just will not be sufficient capacity to ensure that access will be readily available. And that's pretty much true regardless of whether you're talking about primary care or whether you're talking about specialty care. So Dr. Sepchik mentioned a little bit about our workforce. I thought I would take a couple minutes to just tell you a few things that we do know about our workforce. From our 2012 survey of physicians, we know that almost 53% of our active physicians in Michigan are aged 55 or older. We know that a quarter of our actively practicing physicians are aged 65 or older. We know that about 46% of active physicians plan to only practice medicine for 1 to 10 more years. And we know that the percentage of physicians planning to retire in the next 3 years has doubled since 2006 from 4% to 8%. And if you take into consideration the improvement in our economy, I'm guessing that if you ask that question today, that rate would actually be a bit higher as people are more comfortable about the thought of entering retirement. About 12% of physicians providing patient care report their practice is full and they cannot accept new patients. And about 46% report that their practice is nearly full and they can accept only a few new patients. So if you take the access issue and you take the aging of our workforce and that additional nearly million people, we have an issue. And what do we know about the nursing workforce? Well, from our 2011 nursing survey, we know that about 37% of active registered nurses are age 55 or older and the average age is nearly 49. 41% of all active RNs plan to practice nursing for only 1 to 10 more years. And of nurse practitioners, nearly 40% plan to practice for only 1 to 10 more years. And we often like to think about nurse practitioners and advanced practice nurses being part of the solution to the physician workforce. Well, only about 39% of nurse practitioners practice in primary care. And that's 19% in family medicine, just under 10 in pediatrics, and 10% in internal medicine. And whether or not you consider that to be primary care, it may be a little bit less than 39%. So truly, if you take their aging and where they practice, again, it's not part of the solution either. So clearly we have reason to be concerned about capacity. Traditionally, and there's lots of people here who have probably heard me say this more than once, but we look at increasing capacity in primarily two ways. One is by increasing the educational pipeline so that we are producing more. And if you think about those demographics, there's no pipeline that can produce what we need. And the other way is to change regulations to allow professions to practice differently, and that's sometimes a hard hill to climb. But even if you were able to do both of those things, both of them together cannot achieve the balance we need between supply and demand. So I'd like to suggest that team-based care provides a way to increase provider capacity, and we're right now actively involved in the State Innovation Model Planning Grant, as mentioned by Senator Marlowe, and that's about reforming both the healthcare delivery system and the payment system for Medicare, Medicaid, and children's health, but also broader to all payers. And we've been talking about workforce issues and really talking about how do you build capacity within this reformed system. And we've turned to looking at interprofessional practice as a way to do that, assuming that if we can't produce enough and we can't get laws changed fast enough to do that, this is perhaps a way to do that. We can do that through the adoption of interprofessional education models in academic settings. We can couple that with a broader interpretation of what we mean by delegation, as described in the Public Health Code, who can delegate what and who they can delegate to and what exactly can be delegated. And then the transformation of practices into patient-centered medical homes or health homes or other models of care. Interprofessional practice gives health professionals the opportunity to practice in a way that allows them to utilize their education and training to the fullest extent possible. It lets physicians see those patients who are the most complex. It lets advanced nurse practitioners provide more clinical services. It lets registered nurses delegate more to either licensed or unlicensed persons to help support them. It allows pharmacists to play a larger role in medication management. So kind of across the whole continuum, if you're practicing as a team and recognizing the skills of everyone, you can increase capacity by letting everyone practice at the highest level of their training. In addition to building capacity, interprofessional practice can play a significant role in all of the healthcare system transformation initiatives that are underway. And they help to achieve the goals of those initiatives, improving the quality of care, improving the experience of care, and reducing the cost of care. So what are we doing in Michigan to support interprofessional education and interprofessional practice? Well, I'd like to take a couple minutes to talk about 5 initiatives currently underway in Michigan. And as I understand, following my remarks, you'll have an opportunity to learn a little bit more about those initiatives during the network session. So with that, oops, wrong one. So first we have the West Michigan Interprofessional Education Initiative. The West Michigan Interprofessional Education Initiative is a regional interinstitutional partnership between the Grand Valley State University, Office of the Vice Provost for Health, Michigan State University College of Human Medicine, and Grand Rapids Medical Education Partners. It serves as West Michigan's academic center for excellence in interprofessional education and has incorporated a model of interprofessional education. It works directly with the National Center for Interprofessional Practice and Education as an incubator site. The contacts for this initiative are Jean Nagelkirk and Brenda Paul, and if you want to raise your hand so people can see who you are in the program. FIS State University Interprofessional Wellness Clinic opened in January 2004 and incorporates optometry, nursing, and pharmacy students who treat and educate patients as a team. The clinic has been nationally recognized, receiving the first place interdisciplinary award in the 2004 Department of Health and Human Services Secretary's Award for Innovation in Health Promotion. Students learn how to take a team-based approach to primarily treating patients with diabetes, but also high blood pressure, high cholesterol, asthma, and emphysema, among other conditions. And the contact for this initiative is Dean Luplow, who is back in the back. So Dr. Sevchuk mentioned the work at Michigan State University earlier. MSU's Faculty Development Series is divided into 3 sections that address team member attributes, overcoming barriers to interprofessional education and care, and developing activities for the classroom, lab, and clinical setting, with the goal of simulating the experience of working in an interdisciplinary group. As mentioned, the participants that complete the 3 workshops receive a certificate of completion. The contact for this program is Deborah Young, and I guess Kathy Forrest is standing in for her today. My right. The University of Michigan. Their interprofessional clinical immersion experience seeks to improve learning, patient care, and organizational efficiency through an interprofessional education model for primary healthcare environments that is financially self-sustaining. Outcomes include improved patient care, patient satisfaction in their care, learning by both students and staff, and organizational efficiencies for the faculty. The contacts are Bill Piskorowski, Mark Fitzgerald, and Howard Hamerick, and they are here. And I believe our last initiative is the Education to Practice Initiative, which is a statewide initiative under the leadership of the Michigan Health Council, and it's sponsored in part by the Michigan Department of Community Health. Conducts outreach to clinical environments where collaborative learning can occur, shares leading practices and publicly available resources, connects educators and health providers with interprofessional models that meet their needs, and convenes state, national, and international stakeholders through quarterly work groups and an annual conference. And the contact for that initiative is David Miller. David's in the back. So those are the 5 initiatives that are being highlighted today. At this point, do you want me to take questions, Esther, or do you want to move right to the...
No, take questions.
All right. I would be happy to answer some questions if you have them.
Yes, I do have a question. Have you found that there's a great need to educate clients or patients? Because I see you as being very good in educating the professional, but changing the attitudes of clients to go and see the nurse
You know, that's probably not a good question for me to answer since I work on the bureaucratic side. But I would guess that during your network session and when you have an opportunity to talk to folks from those 5 programs, that would be a good question to answer, or perhaps Dr. Sepchik. I will tell you that one of the reasons in our State Innovation Model Grant that we started talking about how interprofessional practice might fit in that model was trying to make the transition from the academic center where students are learning how to practice in the interprofessional way. But then when they're going out in the practices haven't quite made that transformation yet. So we saw the State Innovation Model Grant and the reforming of the delivery system as a way to maybe advance that in practices. So in the same sense that there needs to be an evolution on the practice side, I am guessing that there is a need also to do that on the patient side. That's just intuitively I've heard. Any other questions? Well, thank you very much for the opportunity to talk a little bit about interprofessional practice and give it some context for the remaining part of our afternoon.
Thank you, Milani. I'd like for you to grab your box lunches. It's in that back room there, and get to visit with the various expertise that are here today, and then we'll convene for a short closing. Again, I would really love for you to complete the green form. Thank you very much in advance, and please grab yourself a box lunch.